Welcome to the EKG Guy, and welcome to this week's EKG of the Week. I'm glad you could join us if this is your first time. So this week we have a 34-year-old male who presents with hypertensive emergency. Okay, and this EKG is shown here. Why don't you pause the video, take a moment to go through it yourself, and when you're ready, we'll walk through this EKG together. Alright, so hopefully you had a chance to go through this yourself. We have our 34-year-old male presenting with hypertensive emergency in this EKG. Let's take a look at each one of these, okay? Again, we go through our steps starting with regularity. So what is the regularity of this rhythm, okay? And one of the best ways and leads you should focus on are these leads down here called the rhythm strips of the leads, okay? And these are the standard 12-lead EKGs we get here at Mayo Clinic and how they're printed out. Okay, so let's in this case use lead 2. Okay, in lead 2, what we're going to be looking for, and the main things, you can use intervals that are consistent, are these R to R intervals. Okay, so this is an R wave here, and we're going to find the next R wave, which is this one here, and we call this duration or interval an R to R interval. Then we find the next R wave, which is this one, and that's an R to R interval, and then there's one here. Okay, so as you can see from all of these R to R intervals, these R waves of our QRS complexes, we look at them all. Okay, sometimes you can do this simply by eye or using the calipers if you got the course or if your own pair. Okay, and you can see this is kind of blurred within there, but all of these are pretty much the same. So all of these intervals from here to the next one, to the one that follows, all of them, if you look at them, are pretty close. We would call this a regular rhythm because of that. Okay, the intervals are consistent throughout, and that's why it's a regular rhythm. Next, we look at the rate, and we find the regularity first because finding the rate, there's multiple ways of doing it. Okay, but there are only so many ways you can find it if you don't have a regular rhythm. So in this case, we have a regular rhythm, so there's a few ways we can find it. One easy way is by counting the complexes going across, multiplying by 6, and then finding the rate in beats per minute. And we can do that because the standard EKG from beginning all the way to the end, which I've presented here for you, is 10 seconds. So you're having a 10-second glance of the electrical activity in the patient's heart. And 10 seconds times 6 is 60 seconds. Okay, so if this is 10 seconds, imagine 6 of those to get you to 60 seconds or 1 minute. And that's simply what we're doing here. We're finding the number of complexes, multiplying by 6, and giving us the rates in beats per minute. Okay, so we can do that. In this case, we'll find the ventricular rate by counting these QRS complexes, or you could do the T waves. So we do one here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Okay, and from that you want to do 14 times 6. All right, and we should do our math, so let's just do it here. 14 times 6 is 84 beats per minute. Hopefully I did that correct. All right, so hopefully we got 84 or a close estimate of what the rate is, and that's the ventricular rate. So we got around 84 beats per minute, if I did my math correctly. Now the actual rate that the machine gave us was 88. Okay, so not too far off otherwise. Okay, so that is the ventricular rate. Now another way we could do it, because we have a regular rhythm, is finding one of those R waves that falls on one of those thick lines, okay, and then finding the following R wave and then taking that and dividing by the 300 as our numerator. So let's do that here. So imagine that we have this R wave falling there, okay, and here's the next R wave, one right there. So now we want to count those thick lines, these red thick ones between it. So we have 1, 2, 3, and it's between 3 and 4, but closer to the 4 side. So if you did 300 over 3, that equals 100, and then if you do 300 over 4, that equals 75. But we said it's closer to the 4 end, so it's going to be closer to this end. Okay, and we have a good estimate, so that gives us a rate around that, which is close to what we got. Okay, and we get these bottom numbers are the ones that the number of thick lines. Okay, and this 300 is set because that's the number of those big boxes over 1 minute. All right. So hopefully that makes sense. So the best way to do it, if you want to know for regular and irregular rhythms, if you want to learn one way, was the first way where you multiply it by 6. And you can do the same thing for the atrial rate by counting the P waves going across, so these ones here, and multiplying by 6. All right. Normally the machine only gives you the ventricular rate, but as we know, these machines are notoriously poor, and as we're seeing here, right, we're doing a lot of artificial intelligence research, and we're showing that a lot of the AI stuff that we're developing is really outperforming it, and we'll have a few of those articles coming out soon, so stay tuned. AI is likely the future of EKG interpretation. So anyways, back to what we're doing here. The rhythm origin is the next step. Where in the heart is the rhythm originating from? That's pretty much the question when I have this rhythm origin stated there. So the best way to look at it, or there's multiple ways, but my training or thought process with this are the complexes, the QRS complexes, narrow or wide? Okay, so from beginning, so if you imagine what I'm asking myself, is this narrow or wide? If it's wide, we may have aberrant conduction coming from a supraventricular source, or it may be coming from the ventricles. Okay, and the next thing we look for before, and imagine these ones are actually narrow, the QRS was 114, so below that 120 millisecond mark, is looking for P waves. Okay, so you have your QRS complexes. Let's use a color here. And then you look and you see these P waves. Okay, maybe it's better to look here. Here's a P wave and QRS. So I see a P wave preceding every QRS, so I know we have some sort of supraventricular source. And what do I mean by supraventricular source? I mean that it's originating from above the ventricles. So imagine this here as your heart. Okay, I'm very simple with teaching. So this is your right atrium, right ventricle, and left ventricle. Supraventricular means simply coming from above the ventricles, if you see those P waves proceeding. Okay, so, and not only that, you see those P waves proceeding, it's likely coming from an atrial source, from the right atrium or left atrium, or the sinus node that sits up here. And that's what we have to ask ourselves. Now that we know that we likely have a supraventricular source, we have P waves that look the same, they're coming from the atria, we have to ask ourselves, is sinus rhythm present? Okay, so if sinus rhythm is present, what we want to have, here's your right atrium, this is the sinus node. Sinus rhythm means that the rhythm is originating from the sinus node. If you say normal sinus rhythm, that means you have a normal rate, and that's age-related, in this case between 60 and 100 in adults. Sinus bradycardia is one where the rate's below 60 and sinus tachycardia above 100. Okay, so regardless if it's normal sinus rhythm or sinus bradycardia or sinus tachycardia, we're saying that the rhythm is originating from the sinus node, at least one of the rhythms, right? Sometimes you can have more than one rhythm going on. So we have sinus node here. And imagine that now we take this right atrium, okay? And I'm going to put the right atrium right here. And we'll put our sinus node, which is this one in green, right there. Now from our sinus node, we have some conduction pathways. We go to the AV node, the His bundle, the right bundle branch, the left bundle branch, and the anterior and posterior fascicle. So notice that you're going from, and you also have a Bachmann bundle that depolarizes the left side. So notice you're going from the sinus node and mostly in this direction. So mostly in that direction. And this is important when we talk about vectors, okay, because pretty much what we see on the EKG are these vectors that we're describing. So we have lead 1 that sits here, lead AVF that sits here. Okay, lead 2 is at positive 60 degrees, lead 3 is here, lead AVR is here. And then in the horizontal plane you have V4, V5, and V6, okay? So hopefully that makes sense. So we said we have this red vector heading in that direction. And what that means is you have a depolarization wave heading towards these leads, which means that in those leads that are over here, you're going to see positive P waves, okay? P waves, because remember, we're in the atria, and the atria represent, or the P waves represent atrial depolarization. Now notice it's moving away from AVR. So in AVR we should see negative P waves in sinus rhythm. Okay, so now let's see if we have sinus rhythm present. Okay, if not, we can say we have an ectopic atrial rhythm. So let's look at our leads. Let's look at lead 1, which is here. Okay, we also mentioned lead 2. AVF is down here. Okay, V4, V5, and V6. And we said these leads we should see upright P waves. Okay, notice that they're upright. And the P waves should look the same within that lead. So the best one is to look at lead 2 and notice that all these P waves look quite similar throughout. Okay, there's some P waves here that are upright in AVF, V4, V5, and V6. And then we said AVR should show negative ones, which are here. And these are negative P waves. So hopefully that makes sense. And what this indicates is that we do in fact have a sinus rhythm. Okay, what else can we tell? Sinus rhythm with a normal rate, that's normal sinus rhythm. So pretty much we already have and should know that normal sinus rhythm is present here. Okay. Next, we want to look at the ventricular axis. Okay, so we just looked at the P wave axis, showing that it's between this region here. Now there's a ventricular axis, and the ventricular axis, as you would expect, has to do with the ventricles, whether it's the depolarization axis of the QRS complex or the T wave axis. Okay, and we're going to focus on the depolarization wave of these ventricles. Now, normal ventricular axis is between -30 and about positive 110 or 105 degrees in that region there. We consider that normal. We consider this region here left axis deviation, this right axis deviation, and up here a northwest or superior rightward axis. Here's north, here's west, and that's where we get the northwest. Okay, so we now have to ask ourselves, is this a normal axis? Okay, does it lie within this region here? So the leads to look for will be lead 1 that sits here and lead AVF. That's what we'll start with. Okay, that tends to make things easier. So let's draw these out. Okay, so now that you know that, let's look at leads 1 and AVF. Here's our quadrant. Here's 1. Here's AVF. Lead 1, mostly positive QRS complexes. So we'll go towards the positive end, which is this one, of lead 1. This is the positive end of AVF. So next we look at AVF. Okay, AVF is down here, and this is mostly negative. So we'll go away from the positive end in this direction, meaning that our axis lies between this region here. Now we said that this area is normal in adults, and this one is a left axis. So we have to ask ourselves, where do we lie? Are we within that normal region? Now, one way to do that is by knowing that lead 2, the positive end, sits here at positive 60 degrees, and then perpendicular to lead 2 is in fact this right here, which is -30 degrees, which was that cutoff point. Okay, what that means is if lead 2 is positive, will be on this edge, okay, the normal side. If it's negative, it'll be on this side. Okay, so we have to look at lead 2, which is this one down here, or you can look here. All right, and if you look at lead 2, you can see that it almost looks like these are mostly negative. Okay, and then maybe this is isoelectric, some of these. All right, so it's pretty much right on that line, right on the isoelectric side. So right near -30 degrees. Now the ventricular axis that the machine got was -27, so like right around there. All right, so you may say within normal limits, but certainly on that border line. Okay, so we can say borderline left axis deviation, you could say, or more of a leftward shift. This is a young male presenting with hypertensive emergency, so it's kind of strange to already see a young male with already high blood pressure and having this leftward shift. So this is a normal axis because it's within that normal region, right? So this up until -27, but I would certainly put a square around this because this is not so normal, I'd say, in this younger male. Okay. Next, we want to look at atrial conduction, and this is where we're focusing on those P waves. Okay, are the P waves normal or abnormal? Okay, so this is the P waves, and the best leads to look for P wave abnormalities are lead 2 and lead V1. Okay, so what's nice is we have these rhythm strips that show both of those. So let's take a look at that now. So if we look at lead 2, remember, when we look at our P wave, we said we're in sinus rhythm. The sinus, it's starting from the right side and then moving to the left side, okay? Meaning that the right atrium depolarizes before the left atrium. Why is that important? Well, that's how it shows up on the EKG, okay? The beginning portion of the P wave represents right atrial depolarization, where the latter portion is left atrial depolarization. And that's easiest to see in lead V1. So if you imagine V1 down here, these are our P waves. Notice you kind of have some, almost a biphasic, not so much there, but then you have this deep, okay? This initial portion here is the right atrium depolarizing, and this latter portion that you're seeing mostly of is the left atrium depolarizing. In V1, the criterion is if this is at least 1 millimeter deep by 1 millimeter wide, that meets the criteria for left atrial enlargement, okay? So you already meet that criteria, okay? And then the other one in lead 2 is by knowing, remember the beginning is right atrial depolarizing, then the left atrium depolarizing, so problems are going to stretch it, and then you also kind of get this M-shaped P wave in lead 2. Okay, so it kind of looks like that. Maybe you don't see it so much, maybe showing up here, but we already met it in V1. So this is V1, this is lead 2. So that's left atrium. Right atrial problems, we're going to be focusing on here in the beginning, which we don't see them in V1. Okay, and then in lead 2, you'll see peaking. Okay, so you'll see, instead of the M notching, like in left atrial enlargement, you'll see these peaking, and the peaking has to be at least 2.5 millimeters. And in fact, it is quite close, okay, but it actually doesn't make it. But I'll let you know that a few months later, the patient did end up having some right atrial issues. So close here, but didn't meet it, so we won't call it here. All right. So we do have left atrial enlargement, and hopefully that makes sense. So already a lot going on here. So let's move on to AV conduction. AV conduction, so we looked at the P wave. As you can see, we're making our way through. Now we're looking from the PR interval, so from the beginning of our P wave up until the QRS complex, not to miss anything. And the PR interval in adults is normal between 120 and 200 milliseconds. In this patient, it was actually 200 milliseconds, so right at the upper limit of that normal. Okay, so do you call that first degree AV block? Maybe technically yes. Okay, so it's there. So we could call this first degree AV block. The PR interval was 200 milliseconds. Okay, so by the machine, and where you're looking for is it being at least one of these big boxes in width. So let's see if we can find a good one for you here. So from this portion here up until there, you can see that it's pretty much one full box. All right, so we can say first degree AV block. There's no drop beats, right, that we see here, so that's all we have, no further or higher degree AV block. Next, let's look at the IV conduction, all right, the QRS interval, so from beginning to end of this. And the normal QRS interval should be between 70 and 110 milliseconds, or less than 120 milliseconds. In this case, the patient's was 114 milliseconds. So I would say on the upper end of normal, but still not abnormal. So we'll just say normal for now. Okay, so within that normal range, all right, at least the upper limits and not prolonged. So less than 120. All right, next let's look at the PR segment. Okay, in the PR segment, if we draw our complexes again, remember we looked at the PR interval, the PR segment from this portion here. Is it elevated or depressed? Well, in this case, I did not see much or significant issues here, so we will say no. All right, and now how about the Q waves? Do you see any abnormal Q waves? Remember, the Q waves are the first negative deflection that we can see of our QRS complexes that precede the R wave. And in this case, you may have some Q waves here, per se, in the inferior leads, okay, and even one starting up there. And these ones might be significant there. So we do have some Q waves in leads 3 and AVF, okay. And then if we look at the ST segment, the ST segment is this portion here. We're asking ourselves, is it depressed? Is this J point depressed or elevated? Well, you may see some here, okay, in that per se. So some ST segment issues there, but not significant enough. No, nothing that we would be concerned with regard to this. The patient actually did not have any ischemia. So we will get to that in a little bit, but there's a little bit of elevation, maybe some T-wave inversion there as well. Okay, so as we go through that, we're noticing that. What else do we have? Okay, so we have the QTC interval, which is from the beginning of our Q wave up until the end, and we look at the QTC, which corrects for heart rate, and this patient's was 484 milliseconds, okay, and that is actually prolonged for a male patient. The upper limit in males is usually around 440. Females a little longer. So in this case, we would want to note that this is a prolonged QTC interval. Now, is there anything else? Well, there is one thing that I want to note. Now, in terms of left ventricular hypertrophy, this patient with hypertensive emergency, with a left axis shift almost there, right, we want to keep an eye out on this, okay? And this is LVH, left ventricular hypertrophy. Now, it doesn't so much meet the criteria by using the Sokolow's line. We're using the precordial leads, okay? However, there is another criteria called the Cornell criteria that we should be aware of. And the Cornell criteria looks at the R wave in AVL, and it adds it to the S wave in V3. Okay, and in male and female have something different. In men, greater than 28 millimeters, which we have a male patient, so that's it there. In females, it's actually greater than 20, so in females, okay, so the male cutoff. So let's look at this here. The R wave in AVL and the S wave in V3. So if you look here, the R wave, oh, maybe it's about 7, okay, and then if we look at the S wave here, this is quite deep. So if you take this baseline and measure it all the way down, okay, so look, it's at least 1, 2, 3, 4, 5, almost 6. So at least 5. So if say it's at the bare minimum 5, that's already greater than 30. Okay, so above that cutoff. So there is evidence of LVH here. Okay, and that the LVH is actually what's causing some of these elevations here, that strain pattern you may call it, in those leads. All right, not so much ischemia, all right, although he may be getting there with how high his blood pressures were when he came in. Okay, they were in the 200s, so his systolic. All right, so next we look at R wave progression, and R wave progression is in the precordial leads. So these leads here, we want the R wave to increase from here all the way to V5, okay? And as you can see, it kind of slowly increases up until here, up until V5, and you see a huge spike. So that's kind of a strange thing. You normally want to see it slowly increasing, but you see these deep S waves that are causing that, and that's likely because the patient had LVH, left ventricular hypertrophy, causing that strain. So in this case, I would call it poor R wave progression. Okay, and next the transitional zone, so meaning where are we going from positive to, or mostly negative to mostly positive complexes in these precordial leads. So notice this is mostly negative, mostly negative, mostly negative, again mostly negative, and it seems like if you look from here to here, it might be around V5. Okay, so later, normal transition from going negative positive is between V3 and V4. So it's happening later, so we would call this a late transition, okay, or clockwise rotation. So a lot going on here, and one other thing that you may want to note is that there's that RSR prime pattern in V1, RSR prime pattern, and then some slurred S waves here, not so much in V6, okay, but one thing to note. All right, and that's a pattern of incomplete right bundle branch block. So a lot going on here. Let's make our final interpretation. So regular rhythm, normal rate, and sinus rhythm. So we call that normal sinus rhythm, and we say with first degree AV block, because we saw that reaching 200 beats per minute, no dropped beats. Okay, we had that leftward shift in the axis, and that was likely due to the LVH pattern that we saw. We said we had an incomplete right bundle branch block. All right, and this patient did actually have a prior inferior infarct that we saw here with those Q waves. So he had a prior inferior infarct that may be contributing to this left axis shift on top of that LVH. So prior inferior infarct. Okay, so and then we also mentioned the prolonged QTC interval. Okay, so a lot going on here that we're noticing. So good job if you were able to pick up on some of those. There's a lot going on here that I was picking up as we're going, and not to forget the left atrial enlargement. Okay, we said that was clear here. And the left atrial enlargement, very significant here, likely because of the left ventricular pressures. If you imagine, here's your left ventricle pushing back on your left atrium, enlarging that, causing the strain, and that's why you see the shift more leftward. And you have the inferior portion of the heart not working well, so the force is again pushed leftward. So a lot going on here. He actually had a prior EKG that showed normal sinus rhythm. That was it. Okay, so these are very big changes. A young male coming in with hypertensive emergency, was actually refractory to a lot of medications, and has a lot of changes that we're seeing, and likely a consequence of uncontrolled hypertension. Very non-compliant with medications, and has brought him in with this. So hopefully you were able to pick up and see what we got from this EKG, and there's quite a bit that we can learn and garner from EKGs in general. So our 34-year-old male with presenting with hypertensive emergency in this EKG shows normal sinus rhythm with first-degree AV block, left atrial enlargement, left ventricular hypertrophy as well, incomplete right bundle branch as well as a prior inferior infarct, okay, and prolonged QTC interval. So that's the end of this week's EKG of the week. I hope you learned something. Now I want to make you aware of our EKG coding reference that many of you are already using. How to get access, okay? So you want to go to this link here. So put in that link into into the computer, into your internet source, and then put your email address here when you get to that, and then you're going to use my password here to put in there. Make sure you're using my password every time, okay? And let me just erase here. So this one here, all lowercase, put that in, and then click submit. Confirm your email. So check your email, get a confirmation, and you'll have access, okay? And access here will be this, and you'll start to see that we have examples, and I'm now adding videos into it. So this is an on-the-go reference, has everything you could possibly imagine we use as we're building the course for our fellows here at Mayo Clinic, and so forth. So I think it's quite handy. Our techs are using it. We're using it for coding here as well. So very helpful way to learn, to use as a reference, and so forth. Okay, and you'll see a lot of the things we discussed in this lecture there as well. All right, so a few things. If you thought this was helpful, if you did, yes or no, I would like to know how I can improve, what kind of topics you want. Please leave them below. Like this video if you find this helpful, and share with friends. If you want more practice, okay, obviously more practice is on our Facebook page, where there's almost 500,000 of you there, and thank you for your support. We have daily questions, trying to get back to you between our clinics and making sure we're staying in touch. So go there for practice. There's daily practice. I leave resources. You can find us on Twitter, search the EKG Guy, YouTube obviously, and Facebook. Okay, it's hard to keep up with all these things, so find us there. Share with your friends if you find this helpful, and please leave a comment if there's any topic, or just kind words. We always appreciate it, and I hope you learned something today. Well, thank you for making us the largest, fastest growing EKG community in the world.